Good evening, good morning, and good afternoon for everybody, for all of us. It is our pleasure to welcome you to the third ITM alumni webinar, which will be focusing on COVID-19 in India, and more precisely on the primary healthcare preparedness and inequitable effects of the lockdowns. In the ITM alumni webinars on COVID-19, ITM alumni present their impressions on the current situation of the outbreak in their country and highlight how they are engaged in this global fight against the pandemic. The main aim of this series of webinars is to share experiences, expertise, and good practices within the ITM community of alumni, students, staff, partner institutions, and the wider global health community. I will now give you an explanation of some of the practicalities of this webinar. If you want to ask a question, you can use the Q&A option you will have below your screen. You can ask a question anonymously if you would choose to do so. You can upvote a question by clicking the thumbs up. Questions will be moderated and only a selected number of questions can be discussed given the limited time. Unanswered questions cannot be answered individually afterwards, for which we apologize. You can, however, use the forum function in the online alumni platform to start a discussion on your questions left after this webinar, and also, of course, follow the next webinar. Questions related to technical issues will be answered by ITM colleague Jan Kennis, and we also have ITM colleague Marian Pirar with us to take care of managing the questions. At the end of this webinar, a short survey will be displayed and a browser window will open to give your feedback. The webinar is being recorded and will be made available afterwards on the ITM YouTube channel. You will get a link through email together with the announcement of the next webinar, which will be organized on the 20th of May. Our today's moderator is Professor Dr. Bart Kriel. Bart Kriel is a medical doctor by training, professor at the Public Health Department of ITM, and currently director of the MPH course. He has vast experience in the study of health systems and policies in various sub-Saharan African countries, but also in India and Belgium. His principal domains of interest and expertise are twofold: management of local district health systems in a primary healthcare perspective on the one hand, and the design and management of social health protection policies in a universal health coverage perspective on the other. Bart, please.
Thank you very much, Charlotte, for this introduction. Hello to all of you, where you may be, in Africa, in Asia, in Latin America. It is my pleasure to moderate this webinar, which will be centered around the presentation by Dr. Prashanth. Before saying a word on Prashanth himself, let me first say a couple of things on the institution he is working at. Prashanth is actually faculty of the Institute of Public Health in Bangalore, in Karnataka state in southern India. And IPH has been a former institutional partner of ITM in the framework agreement for a great number of years. But today we still have very strong links in terms of education, in terms of the Emerging Voices Network, but also in terms of health systems and policy research. And currently we're also finalizing a memorandum of understanding between ITM and IPH to seal that very strong links. Prashanth is by training a medical doctor. He is an MPH alumnus from this institute. He did the MPH he obtained his degree in 2008 and later obtained a PhD at the Université Catholique de Louvain in 2015 with the contribution of ITM. Since a couple of days, this is very fresh news, Prashanth is also a member of ITM's General Council, one of the most important governance bodies of this institute. And he will, together with some other people, represent the Global South in this body. He will also be a member of the MPH jury next month in June the MPH health systems and disease control. Now, Prashanth is a very versatile man. I could speak for a long time about the various things he's doing. I want to summarize it with 5 points that are key, I think, to his professional identity. First one, Prashanth is as well a practitioner, as a researcher, as an activist, like very many of his colleagues at IPH. Secondly, he's very much involved and motivated and inspired by the philosophy and the strategy of primary healthcare as defined in Alma Ata and Astana. Thirdly, Prashanth has been involved in the past and still today in the study of mental health care. Fourth, he's very much working on equity and actually leading also the equity cluster in IPH. And fifth, last but not least, we may come back to that in the webinar, sorry. He's working a lot with tribal communities, with indigenous populations in India. Good. Having said this, we will give the floor to Prashanth. We agreed, Prashanth and ourselves, that he would try to do this in a big 20 minutes, at the most half an hour, so that we still have a half an hour left for your questions, your comments, and exchanges. Please, Prashanth, the floor is yours.
Yeah, thank you very much, Bart and Charlotte. I hope I'm audible, and if not, I request Bart to come in and let me know. I'm indeed very happy to be giving this presentation, and like Bart indicated, I will try to finish in 20 minutes so that there is sufficient time for an exchange following that. Just one disclaimer perhaps is that, as many of you probably know and understand, COVID-19 has multidimensional effects. There's a huge social component to it, there's a huge biomedical, there's a huge virology component to it, there's global politics and various aspects to this pandemic. So I'm obviously not an expert on many of these things, while some of the talk that I have prepared for today focuses on areas that I have reasonable expertise in. Some others will be more perspectives coming from my experience and my position in this pandemic, being located at a public health research field station of the Institute in a fairly remote region in southern Karnataka, from where we do some of our work on tribal health research. With that, I guess one thing that this pandemic has clearly produced is a huge number of dashboards, and models is another aspect which we'll come to later. This, what you see here is a situation a few days back on 4th May. This has further increased as expected. We are talking of about 42,000 confirmed cases as of 4th May, and increasing with the trend of positivity increasing day by day. But one thing to note is, in a country like India, as in many other large countries, the distribution is very different. You have some states, for example, here in the western parts, which are reporting a much larger number of confirmed cases, whereas other states which are much lower. And that gives an idea that even within India, you have states and regions which are all in a fairly different stage in the same pandemic. And this is a reflection, I guess, of the global reality as well. Different states, regions, and countries seem to be at very different stages in the pandemic, which is often neglected when we make cross-country comparisons and when we have tables of data comparing one country to another. If we do not understand that these different regions are in very different stages of this pandemic. Another slide. In this slide, for those of you who are not familiar with India, these are the different Indian states with the x-axis showing the number of samples tested, and on the y-axis the positivity per million. And you can see that some states are testing a lot of samples, not having a much higher positivity rate. Many others are in the middle, and many states, for example, especially in northern parts of the country, testing perhaps too few samples. Overall, in India, there has been a lot of media coverage on this. India has not, for various reasons, rapidly expanded its testing. It has been, the government has been quite cautious in defining who shall be tested for COVID, and that has been kept fairly tight from early on. Again, a slide which just shows numbers. I must caution you again that these are all different countries with, at very different stages in the epidemic. So these numbers, firstly, are not comparable because the denominators and populations are different. But the reason I put this slide here is to show that with a billion population, currently, at least for now, the number of deaths in terms of country level mortality to COVID has been smaller than was expected, at least in country. And we'll come back to this because this has given rise to a lot of conversation in press on why this is the cause. So one of the reasons what is being discussed about why the mortality situation in India is lower than expected has been that India locked down quite early. If you can see, according to this graphic prepared based on data from Johns Hopkins, at the time when India announced its lockdown, the number of cases, confirmed cases, was reasonably low, so 500 cases. Whereas many other countries, there's been a lot of debate in the last month on whether there should or should not be a lockdown imposed by countries. And clearly, there has been a contribution from going relatively early in the epidemic into a centrally implemented lockdown. If you see below here, these are the three phases. Our lockdown in India started for a period of 21 days at the first on 25th March. It was only a few days before that the Prime Minister appeared on national television in a sort of a landmark speech where he asked people to apply restraint in moving outside homes. That was on 20th or 21st of March. But very soon after that, from a voluntary restraint, the strategy at the national level shifted into a centralized lockdown. And somewhere in the middle of April, that was extended to a few days back. And then a few days back, we heard of an additional extension. But the third phase of the lockdown appears to allow for much more decentralized implementation than the first two phases. And we'll discuss that in a bit. So one of the biggest sort of medical public health related news that has occupied the press and the science journalists and several educated public at least has been this idea of is there or is there not community transmission. In fact, even today and yesterday, there have been statements put out by authorities that India does not have community transmission. I think this is and the debate to some extent has become a bit artificial in the sense that there is widespread transmission happening in India. On the right side of this table, you see data which the Indian Council of Medical Research published in the Indian Journal of Medical Research. Data from one of their surveillance sites, which showed that a sizable proportion of cases who turned up to be positive among the people with severe acute respiratory illnesses that were being tested. This is data from February, March, and April. Many of them did not have history of foreign travel or contact with known laboratory confirmed case. So it can be argued as to why is this a debate at all? With a highly transmissible viral disease such as COVID-19, why would we not expect lockdowns in such a large country like India to work 100% perfectly? There will be leakages here and there, and the virus is likely to have transmission. But somehow the political and the public imagination has been captured by the idea of trying to prove that the lockdown has prevented community transmission, which is rather unfortunate, I think, because that has also distracted from the idea of preparedness. So where the idea that when you have a lockdown, that you use that time to prepare your primary healthcare systems and your local health systems and various other systems to better respond to the likely increase that might come during the relaxation of the lockdown. Because one thing is clear, we cannot continuously remain in lockdown. And there are a few reasons for that, which I'll explain. Another thing that has really occupied public imagination has been the quest for what I've put here as silver bullets. In fact, in a recent article on the right side of the screen, it's titled "Plasma Therapy is No Silver Bullet." This is, in fact, the Director General of the Indian Council of Medical Research, a very reputed and respected scientist and physician researcher, who talks about how plasma therapy, which is gaining increasing coverage in among science journalists and among the public as a treatment option, is also not a silver bullet. Earlier, I particularly point out this article by Madhukar Pai, who is at McGill University and a global health researcher and commentator, wrote this about how there was extensive reports of how India may do very well because we have extensive BCG coverage, and there was this hypothesis that BCG through unknown immunological mechanisms could be have a protective effect against COVID-19, for which, as he points out, currently there is no evidence. And this hypothesis of BCG being protective has been advanced for various other illnesses in the past, which have not been borne out by subsequent research. And finally, the idea of hydroxychloroquine, which I hope I can say in a rather foolish gesture, the head of a country loosely put out the possibility of using hydroxychloroquine. In India, it has been contentious. There are no good quality trials that are in way. Many are planned. But currently, hydroxychloroquine is being used among healthcare workers. And there's a lot of debate on that, particularly on the lack of evidence for its use and its potential adverse effects. So coming back to the idea that, India might not have as bad an epidemic as many other places. I have put here in this slide a recent article on the mystery of the death rates. And too soon, I think many people are jumping to say that, yes, we are sort of celebrating the lockdown that India went into as having decisively dismantled the damage from the epidemic. But cautionarily, many epidemiologists, many public health professionals in op-eds have pointed out that we are still in a climbing phase of the epidemic. Our demography in terms of the young population is huge, say in comparison to, for example, a country like Italy. Mortality reporting systems, largely the mortalities that are being reported are from hospital deaths, where reporting of deaths is more robust. Whereas if you take community level registration of births and deaths, the Institute for a long time has been pointing out that we need a much more robust system of cause of death and mortality registration, which is problematic. That said, if there are very large number of deaths clustering in an area, it's very difficult to hide it. So it's unlikely that there are extensive number of deaths that are not being reported, yet this remains a factor. The article itself talks of cultural factors related to distancing between people. But most importantly, we must remember that we cannot continue remaining in lockdown forever. In earlier webinars, I've compared the lockdown, our reaction to the lockdown to that of being under a blanket, where we keep peeking out of a blanket to see whether the monster is gone. And then if it's not gone, we just go back. And that cannot be a reasonable reaction given the staggering social and economic effects, especially the unfair social and economic effects that lockdowns have. So we need to be very pragmatic in terms of how long and how strict our lockdowns can be. So as expected, I think the distribution of the epidemic has been very different. This is from a recent map produced by an open data contributor on the internet with public data. And clearly what seems to be the case is that the epidemic is having a very different geographical distribution. Some of it is related to state level governance. Some of it is also related to testing strategy, which changes from one state to state. But one thing that has characterized the response has been the Big Bang approach, a centralized Big Bang approach in terms of implementing a lockdown. To some extent, that decisiveness of a lockdown and its effectiveness of its implementation has not been matched with investments in preparedness, investments in syndromic approaches, investments in more wider strengthening of primary healthcare systems, which are likely to become much more important in the coming weeks, months, or years. And finally, the infections, although have been largely limited to large urban areas, in terms of actual people who are affected, I think the whole country has been affected, because many of these urban areas are completely supported by migrant workers from faraway rural areas. So in some sense, the effects of the epidemic are much wider beyond the immediate area. I think the reason for putting this article here is that right now there's a huge interest in whether herd immunity is the way forward, or continuing lockdowns and that kind of approach is the way forward. That kind of contrast is being imposed, and I think we are in the middle of this epidemic, too quick to be able to decide effectively based on evidence. So a lot of these decisions are being made based on arguments. I think one of the staggering things in terms of the Indian response has been the fact that in the lack of formal social care systems, a lot of the effects of the lockdown have been borne out by informal social networks, benevolence, and charities. And unfortunately, those who are unable to access informal social networks suffer the most. So typically in our case, it has been the extremely poor daily wage workers and migrant workers who are stranded either in cities, and various others, like in the area where I come from, the complete stoppage of daily wage work has taken a heavy toll on people. One interesting development has been, of course, the role of private sector has taken center stage in the public discourse. There has been a severe COVIDization of health systems, and by that I mean that COVID has crowded out various other health conditions and health problems. So this has been a huge problem for various conditions which require chronic care. And of course, the unfair effects. Every one of us cannot work on Zoom. We cannot all work from home. And especially cities in India where a lack of a formal social care system has affected the migrant community a lot. And this is really been the most important learning, I think, in terms of dismantling of our social care systems and more and more dependence on privatization of public services has really multiplied the possible effects that the lockdown might not have had otherwise. In a few slides, I don't wish to elaborate. From the Institute of Public Health, we have been heavily involved with preparing resources for improving preparedness at primary health care levels, because we believe that in the coming weeks to months, preparedness of primary health centers will be central to how well we can respond to the multiple spreads of outbreaks in remote and rural areas which could occur. And that's the reason why we have invested in this. And a lot of this has happened through spontaneous online collaborations. We steered something called as the COVID-19 PHC Action Group, with many others from various parts of the country joining in this effort. And all of this is now available on our website and various other websites. So I think I end in the next few minutes with 4 reflections. One reflection is in general on the modeling and public health. I think the number of disease models that have come up in newspapers, in TV channels, as well as in literature has occupied public imagination. Are we able to predict the effects of epidemics accurately? And as you might have guessed, there are many excellent articles online on the utility of models. Models are as good as the data that we put into them, and they're as good as the assumptions we make in making them. So in settings where data is not good enough, the model is not good enough. And secondly is the public health. The idea of public health in India has not captured public imagination. And I suspect that in a post-COVID India, public health and population health will be very important words and will drive a lot of policy discourse. The second reflection that I offer is on One Health. The idea that different sectors have to be involved in disease response. I recently gave a webinar focusing on One Health that is available on YouTube. But to summarize that, I think the importance of reimagining our lifestyles and economies, because a lot of the emerging infectious diseases are zoonotic in origin, and they completely undermine decades of investment in health systems. If you take the Indian state of Kerala, for example, in South India, which has done exemplary work in terms of its response to COVID and has kept mortalities very low, the reason it has been able to do it is because for decades it has been investing in health workers, primary healthcare systems, and publicly delivered robust social care systems, formal social care systems. So it's so easy if we do not develop an intersectoral mentality to disease, to be able to lose all those gains, be it in immunization and be it in public services, if we don't get into this. And the third one, which is very clear now, is that the burden of the disease is being shared unfairly. So those of us who are able to do work from homes and who have the privilege to be able to to respond to lockdown without having any individual effects are benefiting probably as much as many others who are really suffering the effects of this outbreak. And one thing there is the total cheap labor on which cities in India have been built. We are today paying that price because the complete lack of occupational safety, safeguards, and social care systems is today the reason why several migrant communities are so badly affected in our cities. And a final reflection that I offer is, and I hope will inform the discourse in a post-COVID India, if we can even imagine what that's like, is the safeguarding of the public in public health. Because in some sense, various policy options India has explored in recent time have focused on purchasing private care and on the idea that, okay, this country cannot handle healthcare delivery and various public health activities entirely. So we do strategic purchasing from the private sector. And in the kind of regulatory architecture that India currently has, there's a lot of doubts on whether this kind of a shift is wise or not, given that many of the public goods that we are all benefiting from are not profitable. Things like preparedness for epidemics. Maybe on that count, I would like to pause here because we can keep going on and on these aspects, but maybe we can have some time for discussion.
Yes, okay. Thank you very much, Prashanth, for this nice presentation and also well in time. So we have a big half hour open for questions. Let me look a bit at the many questions that are coming in. Lots of them are on the effects of the lockdown, Prashanth, and from different perspectives. But one perspective that I want you to address in the first place is the socio-economic impact of the lockdown. If you look here in this part of the world, in our welfare states, you have lots of measures within social security system, somehow trying to mitigate the fact that people cannot go and work, that businesses have to close down, that you still have social assistance sort of services, etc. What is happening in that? Is there something happening in that respect in India to try to mitigate the sometimes dramatic social and economic consequences of the lockdown?
Yeah, I think I didn't emphasize enough on the fact that health health and various social services in India are a state subject, which means that different states have organized these in different ways. And to a large extent, I think we can say that those states which have more investments in formal social care systems have done better. For example, Kerala. To some extent, also states that have earlier faced kind of disasters of scale have also done better, interestingly. So there was some recent articles on the state of Odisha, which is not particularly socioeconomically advanced, but has had multiple cyclones. And in some sense, the preparedness of being able to quickly mobilize and rapidly gather resources and respond is also requires some preparedness. And it looks, people are saying that these states' earlier disasters have helped them, better prepare for this one. But
yes.
That said, the kind of social care, formal social care options in India are very limited. If you are in the formal sector, then you have, of course, some labor laws, you have some kind of financial and other measures that protect you. But social security net that is comprehensive enough is lacking. So what you have in effect is a very large informal sector, which in India is very large. People literally who are building our cities, our malls and our IT infrastructure, who are not covered by a robust social care system.
Okay.
And I think those are the ones which are being severely affected.
Okay, we all have seen, I think, or at least many of us, the images on television of these hundreds and thousands of people working in the informal sector in big cities, returning home or walking, for hundreds of miles. And I mean, these people fall without any sort of guaranteed income. Okay, in the same line, Prashanth, there's also a number of questions on how COVID-19, but also the lockdown, how it affects the let's say the functioning of health services and of primary health service. Does it affect utilization? In what way does it affect programs, specific programs like, for instance, EPI, TB? Have you any ideas? Have you any evidence on that sort of secondary impact, which is sometimes termed or labeled under the term collateral damage?
Mm-hmm. No, there is very definitely a huge collateral damage. I mean, I don't know whether that's the best term, but certainly take, for example, pregnancy. We are in many parts of the country, access to safe delivery is still quite problematic. So by safe, we still are talking about access to skilled birth attendants at delivery. So forget still the idea that mothers must feel safe and comfortable while delivering. So that is still a distant dream for many classes. So in that sense, maternity care, diabetics, people with epilepsy, people with mental health conditions, many of these people have had to depend on what I called earlier as the informal networks to be able to access medicines, etc. Public transport is off, so your ability to leverage informal social networks to get transport, a cousin or an uncle who has a private car, for example, these are the kind of ways in which people are coping. And obviously, the better socioeconomically you are, the better you are able to cope with these effects. Immunization, you mentioned, Bart. Immunization was paused, I think, almost up to a week or 10 days back. And as you know, the effects of losing out on immunization will not be immediately evident. It could be in the form of measles outbreak. We already struggle with good coverage of measles. It could be, various other things. So a lot of the effects on the overall healthcare, other than COVID, will only become palpable, I think, in the coming months to years. We do not even know some of those, I think. And I think that's important to keep in mind.
Okay, perhaps a last one on the lockdown. If you look at what is happening in this part of the world, and particularly in Belgium, you see some sort of decreasing willingness of people to comply with the lockdown measures. There's some sort of lockdown fatigue, which needs to be managed very carefully by politicians in dialogue with experts. Is there something similar in India? I mean, are people respecting the lockdown measures? Is it feasible for them? Is the police intervening if this is not happening? Could you say a few words on maintaining the lockdown and people's acceptability to comply with that?
So there's a lot to be said about this, but the short answer is no. I think people anywhere do not respect the need to be locked down in their houses, because this is not a natural state of being, I guess, for many of us. But even there, I think to come back to the unfair effects, for some of us, it's the question of how comfortable are we with the lockdown. But for various others, the question is on survival. Take, for example, communities, tribal communities, or in remote rural communities. Even though there is food being organized, food is still, in many states, the food is being distributed to doorstep, which is commendable. And I think some states have done tremendously well in terms of limiting stigma and ensuring that people can continue to stay at homes and their food is met. But it's not an option for many others. And many of the food being supplied in tribal areas, for example, is largely cereals. And in communities that already have high levels of malnutrition, this is not, again, one of those effects which we will not immediately know. Probably many of them could become even more vulnerable to infection during these. And the mental health effects are staggering, because we are still a country which has not been able to scale up our mental health professional availability even at district level. There are many districts in India which do not have a psychiatrist. So in such a situation, it's becoming very, very difficult to blame entirely individuals in not respecting lockdowns. And if I can make a final point, I think the fatigue is also in terms of weighing the costs of maintaining very strict lockdowns versus how widely and how fairly the benefits are being shared. I think it's very complex. I wouldn't like to say that lockdown is good or bad for India or not, but I think the message is that we need to make these decisions at as decentralized scale as possible. The more and more we centralize it in a big bang approach, what we have is the distribution of its effects is very unfair. One hopes that if it's done in a more decentralized way at village levels, at panchayat levels, perhaps it will be fairer, because it allows a bit negotiation between those affected and those that are implementing the law.
Prashanth, you, together with your colleagues at IPH, you recently developed a sort of guideline for health workers operating at the primary health centers, which is in the public system, let's say the front line, the main, the principal service interacting with community at the first line. Perhaps a first part of the question would be, could you say, describe, but in summary, what is the gist of these measures, of the procedures to be taken at the PHC level? And I want to link to that a second question is, the PHCs, the primary health centers, are in the public sector. Now, we all know that in India, there is a huge growing private sector. So only addressing these guidelines for the public PHCs, but not addressing the private sector, the traditional sector, the rural medical practitioners, etc. So could you, in a second stage, address this diversity, this mixed character of the Indian health system vis-a-vis COVID?
The idea at the time, this was the end of March, when a bunch of us got together and we established something called as a COVID Primary Healthcare Action Group. The reason we came together is because I think at the time the action, so to speak, on how to respond to COVID was largely being driven centrally, quite high up. And there was very limited resource available as to, in a rural primary healthcare setting, what is the kind of preparedness that one has to have. for COVID, ranging from issues of health worker safety, because we know that health workers have a double risk. One is that they themselves are at high risk, but then they can also, especially if they're asymptomatic carriers, transmit infections to really vulnerable population and really multiply the effects of the pandemic. So we focused a lot on how in limited resource settings we can achieve preparedness in government primary health care space. What should be the responsibility, for example, of the ASHA worker, which is the community health worker who is in a village? What should ANMs, the nurse midwives, be doing? And what should be the doctors be doing? And we focus a bit more on the soft aspects as well, because doctors as heading facilities are also expected to be taking care of the mental health and motivation of health workers. So what are the kind of things that doctors must do? You know, how, what kind of activities can they do to keep health workers motivated? Various aspects. I will not go into it. These are all available on the IPH website. And at the time, I think this was very important because we ourselves in a nearby primary health center, there was a lot of confusion as to how should we organize preparedness in my primary health center.
Okay, and then the private sector, Prashanth, the elephant in the room, what is happening there?
The elephant in the room, indeed. It's currently a lot of the private sector is focusing only on tertiary level care. A lot of the high level care in terms of ventilators, etc., are being operated by the private sector. As you know, at the primary healthcare level, the private sector is mainly the village doctor, often unlicensed, some of them practicing traditional methods of treatment. That is, I mean, to put it mildly, much beyond the scope of our discussion, but it is indeed the elephant in the room. And I think even our public health literature itself has not addressed sufficiently what is the kind of systemic inputs needed to create a governance framework for this very diverse kind of private sector we have. One further point, Bart.
Yes.
The private sector, in terms of charismatic clinical specialists, towards the initial part, I think captured the whole space on what India should do, and I think that is unfortunate because in the early parts we were not able to get a public health logic into the policy levels, although that swiftly changed. And I think that was the point I was making earlier. I think the idea that public health is a discipline by itself and that we need to institutionally invest in public health education and teaching, which is largely led by European and American institutions, I hope will be an important learning that we take forward instead of only investing in medical colleges and health specialties.
Okay. Another question refers to the very rich and ancient culture of India and the very diverse cultural, let's say, customs. Would there be any either positive or negative sort of reactions culturally inspired vis-a-vis COVID? Things that are laudable and applaudable and that one would need to encourage, but on the other hand, perhaps also things that may be harmful. Just perhaps a couple of even anecdotal things to illustrate that point, Prashanth.
Yeah, I think the laudable thing has been I would say the heroism displayed by several public servants, people who are at the front lines, not only in health, but in various other public services, ranging from police to fire services to, of course, to health services, the ASHAs. And here is the irony. Many of the community health workers have taken on responsibilities for COVID with very poor investments in personal protective wear. So one wonders whether we celebrate that or do we really say that's shocking and that's not something to celebrate. So it's a bit a mixed thing there. There are many amazing people who are at the front lines fighting this with very limited personal protection to themselves. Another streak has been, unfortunately, this communalization and sort of stigmatization of identities depending. So I think I think this is something that as a human race, I think we all, sorry to sound so philosophical, but we have to really reflect upon, because I think we like to immediately pick upon this nearest other who is really to blame. And we somehow say, okay, this is the guy. It could be either a religion, or it could be that poor migrant, or it could be that someone else who is not like me, who is really the problem and who has to be controlled. And that's why I get a bit worried when you were asking earlier about how are people must all be reacting quite poorly to the lockdown. Yes, they are reacting poorly, but unfortunately, this calling out of someone else who is reacting, who is not following the law based on their identity and religion has taken the center stage. And that is unfortunate, because that has, of course, that as you know, has a history. And the worst time for us to be going down that path is during the pandemic. And that's something I think to all of us must be cautious.
And something else, Prashanth, that is coming up in the questions. And you know, if in this country, experts, medical experts, virologists, microbiologists clinicians play a very important role. And so there is this complex interaction between experts and politicians, which is very nice to observe as a researcher in one way or the other. Is something similar taking place in India? Is there an interaction between, also in the public space, between experts? What sort of experts and politicians? Are experts dominating the debate? Are politicians eventually saying, no, this is our job, we take the decision? Could you elaborate in a couple of lines, on this?
Very complex again, but I think I go back to that theme. The higher up the action is, the more limited the ability for broad-based involvement. And I think earlier on, perhaps for the very right reasons, the decisiveness was central at the phase 1 of the lockdown, where decisions were kept quite close. And I think many countries have done this, not only India. But over a period of time, I wish there were much more decentralization of how we implement the lockdown at finer scales, because that would have allowed a more broad-based involvement beyond a few experts.
If you say decentralization, sorry, Prashanth, to interrupt you. If you say decentralization, okay, that's from the federal level to the state level, because health is a state responsibility. Now, a state in India is as big as France. When you're talking about decentralization, you're going to the districts, the districts, a lower level. Okay, and districts in India are a couple of million of people often.
Yes, we are districts range from 1 to 3 million population. Some are even more. So
that would be the optimal level, you think, to customize policies.
At the very least, I think. And I think at that scale, unfortunately, we are still in an operational level. We are at the level of operationalizing the lockdown rather than thinking what I could do at my district level. But to some extent, this has been because I feel that there was insufficient public health. This is just a personal opinion. It's not an expert opinion or something, but I feel there was insufficient public health guidance at the very initial stage. But over a period of time, the government and the Indian Council of Medical Research and various other bodies have involved a wide range of people, including epidemiologists, to some extent virologists, and others in the response.
Okay, I'm looking at time. We still have 10-15 minutes. That's okay. Perhaps go back to to some of the technicalities. One of the questions is on mass testing. There's a lot of discussion on okay, we should expand the testing and try to target that in some way or the other. What is the policy in India? Do you have are there any plans? Is there capacity to do so? Could you please elaborate a little bit more? Is this some sort of well thought policies, or Prashanth, please, your views on that?
So clearly, if you look at just the figures, India is among the countries which has much lower tests per population, tests per million ratio compared to many other countries. In fact, critics have argued that is the reason why some of our positives is low, because we are not we have adopted a fairly conservative approach to testing. And I think the guiding principle for that has been not to overwhelm our health services. I think there is some logic to that, to not have such a large-scale testing that you end up admitting people into a burdened healthcare system where you cannot ensure safety of health workers or of people admitted. Now that said, I think while initial parts of the epidemic, while that was fair, because at the time, arguably, the transmission was limited to a few hotspots that we had well demarcated. Now, the extensive spread, as you saw in the maps earlier, requires a scaling up of testing capacity that is not there. Now, as far as being able to test samples in a central institution, there is no problem. Actually, the country has done enormously well in terms of at least ensuring a testing center at every district. The problem is that how do you still go further down? We have not invested, for example, like some countries did, in mobile kiosks. We have not invested in, for example, in syndromic approaches where you initiate a probable positive based on a syndromic case definition, and perhaps organize testing later. Some of this did not come early enough, and nor did we invest in kind of serosurveillance and antibody tests, which indicate past infection in areas that are not having current infection.
Okay.
Yeah, okay. I'll pause here because there's a lot to be tested, and there's a lot of lovely op-eds on the topic.
Now, the good pupils, if I may say so, in the class of the Indian states are Tamil Nadu and Kerala. Certainly Tamil Nadu is doing, South India is doing quite well. Do you see noticeable differences in these states that have a tradition of sound policies, public health oriented policies? Are they doing better in trying to cope with COVID than other states that had before COVID already a relatively poor performance? Or are they overtaken as well? Are they overwhelmed as well as?
Kerala, certainly. It's very dramatically different in Kerala. A few things to say. The way in which they have handled early detection and containment at a very small scale, fairly decentralized. The way I was saying earlier, that the response has to be decentralized rather than at state and central levels. Kerala has done that. They have also been at the forefront in issuing out very clear guidelines as to what health workers must do. They were the first state to resume immunization services and various essential services at the earliest. They invested in mental health support and stigma control measures very early before other states. So in some sense, I think the decades of investment that Kerala has made into these is paying off today. But that said, Tamil Nadu is in the last few days in the middle of a sudden spurt in cases because some parts have relaxed the lockdown, and that's really, I mean, I know we're running out of time, but that's really the difficulty with the lockdown, because at some point you relax it, and then what happens? Unless you use the time to prepare yourself better, the lockdown itself is not an end. It was a means to some end, and that has somehow not been realized universally, I think.
Okay. Perhaps two more questions, Prashanth. And the first one actually is mine. If you see what is happening currently in the United States of America, where President Trump is putting China forward as a sort of scapegoat, yes? Is something similar risking to happen in your country, where you also have, if I may say so, a relatively authoritarian leadership? Would it be conceivable that your prime minister is perhaps pointing fingers to the Muslim community?
So I cannot comment on he has not done so,
Okay.
by the way, and I think the messaging from the Prime Minister's office has been reasonable. But I think instead of taking that question and putting the blame on this situation, on the communalization, on the government, I think part of the burden has to be borne by the population, by all of us, I think, in the country. To some extent, these responses have been conditioned by the prevalent situation before. Many of, be it communalization or be it stigma towards migrants or communities, are during this epidemic are feeding off existing prejudices that were always there. And I think this, in the darkest hour, we see our own darkest shadows in some sense. And I think this is a point for reflection at a much greater level than just governments. I think this is a time for India and perhaps many other countries to really face their shadows, because the pandemic really brings out the worst in us. And it's at these times, I think, which test how humane our response is. And I hope we have the strength to remain humane through these difficult times.
Okay, Prashanth, I'm going to end with the last question. That is, I think, a question that is put forward on a universal scale. Is COVID-19 to be a game changer? Is the glass half full or the glass half empty? What would be your analysis in India? Can COVID significantly change things for the better? And if yes, in what way? If not, why not?
I wouldn't say that it will change things for the better, given that it is affecting a lot of people in many different ways. But there are very important lessons. I know what your question is on how is that post-COVID situation going to be. And I think the more and more I read from some of the coverage on the Spanish flu epidemic and previous large-scale pandemics, I think one thing is clear, that this will end. So this is going to go up and it will end. Now the question is, how many deaths will it take in its while it falls? How much of damage will it do to social and economic care? That's the question. And I feel that there will be a lot of questions we will be asking on the other side of this pandemic, which has to do with how we organize public health. And perhaps, in some sense, that game that you speak of, I hope that the question we ask is that, can we safeguard the public in public health? Because health cannot be left alone. It's not a matter of individual choice. It's not a mobile phone that someone gets an iPhone and someone else gets some other model of phone, because health is a public good. And of course, we all know in this community, in the public health community, I think it's so self-evident. But I hope that at the end of the pandemic, at a very societal scale, we are able to say that we have to invest in public services that work for everyone and not only for those who can pay.
Okay.
And I hope that will be the game.
Okay. I abuse a bit of my function as moderator, and a very, very last one. IPH is an academic institution. Just like ITM, for most of us, if not all of us, half of our mails on a daily basis are on COVID. We are very much involved and interested in working on COVID, hence this webinar, but also research proposals are being drafted. It's really a very intense sort of process. What is happening at IPH? Are you investigating, are you working on COVID-19? And if yes, perhaps illustrate this with one or two or three focuses, research questions, research aspects you want to study.
One is, of course, we are investing in improving primary healthcare preparedness, which I will not expand further, and that's available on our website. The second is we've formed a small group which has been like a back-end support to district and state governments in terms of helping rapidly go through international guidelines and adapt them to our settings, because that's a kind of capacity that we have to be able to provide this kind of support for government health services. Thirdly, I think we, as you know, Bart, we have already been working on One Health, the idea of wildlife ecologists, veterinarians, human public health people, doctors, and others need to be coming together for various understanding various zoonotic illnesses. And I think in the coming days, this interest in One Health or intersectoral approaches in general is going to rightly increase. And we hope that in the coming decade, IPH can be at the forefront of trying to ensure a more intersectoral response to various health issues, not only infectious diseases, but also, for example, things like diabetes. You know that some of our colleagues work heavily on tobacco control. There's the question of food. And the thing about COVID-19 is that we quickly forget that there are so many of these wicked problems that are still there, from climate change, antimicrobial resistance, etc. And I think that's something to keep in mind. One of the things I saw online, again by Madhukar Pai, was about not overreacting and making everything into COVID. And I think that's something, as health systems people, we yes. understand that. Yes. We see COVID as part of that larger health system problem and not COVID yes. as a virological problem or yes. as one disease.
Okay. Thank you very much, Prashanth. I think this has been very interesting. Thanks for having shared these ideas with us. It was very pleasant. It was also very pleasant to hear the birds sing behind you. For yes. the audience, Prashanth is living in the Bihar Hills, which is an area with huge tribal populations, and it's in the midst of nature. So it was nice to have
tiger reserve.
Yes, a tiger zone. I hope that these are birds singing. There are no tigers making any noise. Okay, thank you very much. Thank you all to all the people all over the world for having participated, for your many questions. We did our best to select the most frequent questions, but I'm sure that if there is if there are things you would want to discuss with Prashanth, you could do this through the alumni network platform via Charlotte. Thank you very much, and have a good day.
Thank you very much, Bart.